concept of resistance has been with us in psychology and psychiatry for a long time. This is one of my favorite quotes about treatment resistance from Alfred Adler, an early psychoanalyst. Every therapeutic cure, and still more, any even awkward attempt to show the patient the truth, tears him from the cradle of his freedom from responsibility and must therefore reckon with the most vehement resistance. Now, don't you just love how people used to think and talk and write? But it shows us that this concept has been around for a long time, and I think one of the important parts of it is that we should expect to see it in treatment. When you're trying to show people things about themselves that they're not willing or ready to see, you're bound to bump into it. It evokes some strong feelings in people. The concept of treatment resistance has some medical history as well. You hear about treatment-resistant staph, treatment-resistant bacteria of one kind or another. And what they mean is things that don't respond to our usual treatments for those conditions. So psychiatry and psychology in the last few years has become more and more focused on what treatment resistance means for the kinds of people that we see. And what we know is that a substantial number of people, despite advances in medicine, despite evidence-based treatments and all that we're learning about what works and for who, even despite all our advances, a number of people just simply don't respond even to good treatment. So naturally the question is, why is that so? Just a couple of examples. In schizophrenia, 10 to 30% fail to respond to medication, and another 30% respond only partially. But lest we think that only the really sick people don't get better, let's take a garden variety depression. Some research, and there's even more updated research, eventually I'll update my slide to include the newest and latest, but 15 to 50% has been estimated to have a treatment refractory depression that, and a minority of patients recover fully with medication alone. So even something like depression, which we see a lot of, there's still a substantial number of people that don't respond. In our field, in working with people with chemical dependency and substance abuse issues, we know that relapse is just a sad reality of the picture. It's part of the recovery arc. God forbid we get someone with a dual diagnosis or who has a comorbid axis 1 and axis 2 disorder, because then things get really messy, right? So treatment resistance comes in all shapes and sizes. Sometimes it's as simple as not following the rules. When you work with people who are treatment resistant, it can feel like you're trying to move a mountain, right? And sometimes there's these other clients that they just have a way of showing you how upset they are. Right? So for us, what are some characteristics of treatment resistant clients? Well, they typically have had multiple unsuccessful outpatient treatments. By the way, see if any of these, see how many boxes tick for you of the people that you see in your practices. Repeated hospitalizations, repeated crises. These are the kind of folks where you can't get to the treatment or the recovery because you're always trying to manage one behavior or crisis after another. Repeated relapses with drugs and alcohol. These kind of clients often, in my experience, have early trauma, early neglect, or early abuse. They have significantly impaired relationships, often with early, primary caregivers, but also people in positions of authority or people who they depend on. And they obviously have difficulties regulating their emotions. And how that gets played out then is that rather than in words, these are the kind of folks who aren't going to come into your office and say, I'm really, really mad, or I'm really, really sad. They're going to show you in their actions that are self-destructive and in attacks on the therapeutic frame. So what do I mean by some common self-destructive behaviors? Things like repeated self-injurious behaviors, repeated suicide attempts or threats, relapses with substances, troubles with eating or restricting, binging, purging, or other kinds of risky and dangerous behaviors. Do you guys see some of these in your practices and in your work? Yes, lots of nods. You know what I'm driving at here. Okay. What do I mean by attacks on the frame? The frame, the idea of a frame around the treatment is an important one. It's been around a long time. But there's no shortage of clients that we see here, and I'm sure that you see, who in various ways start to poke at the frame. So some common ones are not taking medications as prescribed, not doing homework or following through on treatment recommendations. Oh yeah, doc, I'm going to do it, absolutely. Next time I see you, I'll have that done. But what do they do next time? They come late, they don't come at all, or they stop treatment prematurely. In sessions, they're getting more defensive or angry or refusing to talk about a topic. Or this is a more subtle one that usually you don't pick up on until down the road, but it starts to feel like they're misusing therapy or using therapy perversely. Sometimes this is, I do a lot of supervision, and I'll hear people in training going, I don't know why the person keeps coming. Like, we're not getting anywhere, nothing's happening, I can't break through, but they keep coming, and it almost feels like you're not supposed to get anywhere, right? It's a misuse of therapy. It's not going as it's supposed to do. There's some perverse end to it. Or even something like excessive or requests for outside of session contact. So what I'm going to try to do is present a case that's, I guess, based on a true story or an adapted screenplay from a true story. And it's based on an actual case and then some amalgamation of some other cases. I'm going to present some preliminary information about the case. Then I'm going to talk some more about some more concepts, and then we'll weave the case back in to try to flush it out a little bit. Okay? I'm hopeful that this case speaks to some of your work, or you can find some of your work or some of your clients in the case. Okay? So this is the case of Mr. Smith, who's a 42-year-old man who is presented to an outpatient substance abuse treatment center with a chief complaint of alcohol abuse that's been around for over 12 years. He says he's had depression 3 or 4 times in his life. He's been, unemployed off and on over the past years, often losing his job because he starts becoming absent due to depression and alcohol use. He's been in individual therapy 2 other times and says that they were somewhat helpful in his first meeting. He was once hospitalized briefly for suicidal ideation, but has no history of attempts. Okay? In the beginning in individual therapy, Mr. Smith is initially talkative, active, professes that he's motivated to stay sober, expresses appreciation to the therapist, and tells her that it's helping. However, after 1 month, Mr. Smith starts to arrive late for sessions, shows up having not completed his homework, and a few weeks later, he tells the therapist that he started to drink again and has been thinking more about suicide. Now the therapist is getting concerned. In sessions at that point, Mr. Smith is becoming less talkative, more passive, seems to be not following the advice of his therapist. He seems resistant to focusing on things the therapist thinks are important, even occasionally becoming argumentative and agitated, dare I say angry. In addition to concern, the therapist starts to feel kind of confused. Wait, what happened here? Things were going so well at the beginning. She's getting irritated with the patient, feels that the client has this sense that the client isn't telling the truth, and no longer really looks forward to the sessions and is starting to feel more hopeless about how the treatment's going to unfold. Any of those sound familiar? Okay. I think we've all been in that spot. Okay. Eventually, the therapist gets a call after a few more weeks that Mr. Smith's been admitted to the hospital for a suicidal ideation in the context of a serious relapse with alcohol. Right? So it started out one way, something happens, things start to go down, there's some initial signs of some resistance to the treatment, there is a big major relapse, and then ultimately a hospitalization. So the question then becomes, if we're going to be seeing these kinds of difficult to treat folks, who or what is resistant in the example? Is it the client? Is the client being resistant? Is the treatment being resistant? Is somehow the treatment resistant to the needs of the client? Is the therapist being resistant? Now, I think the answer is probably yes. It's all of those in a way. But we can't really do much about about the client, right? We can't really do much with what they're doing. They're just being themselves, right? So my sense is that it's often the therapist that's being resistant, or at least we're the ones we can do something about, rather than throwing up our hands and running out the door and giving up altogether on the treatment. So often the therapist in my mind is being resistant by not recognizing and addressing some important things. And when you're in the crunch of trying to make something happen in a brief period of time that you might have them, or in a 10-session treatment, God forbid you have a little bit of time to actually get to know the person and do some work. So all of the crunch in time, the limited time you have, really is what threatens these things. These take time. But I argue that the therapist is being resistant because they're not attending to ruptures in the therapeutic alliance. People know what I mean by ruptures in the alliance? When the bond, the felt bond, or there's a disagreement on tasks and goals for treatment. Sometimes there's a resistance to seeing underlying personality characteristics or important interpersonal themes that are exacerbating the substance use disorder and the resistance. Even worse, I have a lot of supervisees who tell me in the first meeting, something about it, the guy was just really narcissistic. And then that plays out, and they don't link it. Well, you saw it in the beginning. Why weren't you anticipating that you would see that character trait come out in the therapy? So there's a real lack of attention and addressing it when it comes up. There's often a lack of agreement on goals and tasks and the methods by which your treatment's going to unfold. You hear clients say, well, I didn't sign up for that. I didn't know it was going to be that you were going to ask me. All that needs to get kind of negotiated in the front end as best you can. A minimizing or a lack of awareness of the effects of early trauma, neglect, and abuse on development and relationships. Not paying attention to negative transference, which often is a way the client has of communicating their anger with you as the therapist. And not attending, lastly, to the meaning of the self-destructive behaviors and attacks on the frame. We'll talk about this later, but of course you have to set limits. There has to be rules and consequences for behaviors, and you have to manage them. But that's only one prong of the attack. The second prong has to be this last one, focusing on the meaning of the behaviors that they're doing. So myself and some of the people here, you'll see there's a book that came out written by some of the people at Austin Riggs about working with treatment-resistant clients, so I can't take credit for a lot of this, but I believe it to my bones, and so I want to share some of it with you. There's some basic assumptions for working with treatment resistance, and the first is a rather radical one. It requires a different stance, seeing patients as having authority and responsibility for their lives, which I think we all would say, oh yeah, I believe that, but do we actually do it in the session? And we'll kind of talk about this one. The word authority means something particular to me that I'll try to flesh out a little bit as we go along. But they're in charge of their lives, whether for their decisions, for the consequences of their decisions, they're responsible for it. And resistance is often a response to a real or perceived loss of this sense of authority, often in relationship to the therapist, the treatment, or even the disease. Sometimes resistance then may be the only way left for a patient to exercise their authority. So, based on these things, resistance is not only to be eliminated, minimized, and reduced, but in my mind, it's a nonverbal, often unconscious communication. It's a code. They're talking in actions in code to you, and that code has meaning. Often, the behaviors are attempts by the patient to communicate their feelings. If I'm doing something really dangerous, it's got direct meaning. It's a communication they're trying to make. Often it's something that they're trying to establish safety from some internal or external perceived or real threat. Something's coming up in them that's a threat to their kind of homeostasis in a sense, or you're doing something or asking them to do something that's a threat to how the balance that they've kind of created for themselves. So I would argue that in addition to developing recovery skills, sometimes your task becomes what I would call cracking the code. You have to start to keep in mind the big picture, not get lost in just the management of the behaviors, but pay attention to the meaning of the behaviors and what they're trying to communicate, and help them translate it into their own words. They don't recognize that they're doing it. They don't recognize it's linked to what they're feeling. So we're going to go through the next few slides are some tips for how to work with these folks, and then we'll get back into the case example to kind of flesh it out a bit more. The first one is, please attend to diagnostic comorbidity. If you really think the person, like I said, has some personality disorder traits, work with it. Expect that it's going to happen. Expect that those traits are going to get played out with you in your treatment with them. Ask about previous treatments. Take the time to do it. What I didn't tell you is when Mr. Smith said that his previous treatments had been somewhat helpful, the way he said it, and this client or therapist I was working with, we were doing some videotaping of sessions, so I'm going to try to do the facial expression that I saw on the tape when this happened, but I'm not going to do it justice, which was something like somewhat helpful, with this snarl and sneer, and the therapist didn't ask any follow-up questions to it, which lost a goldmine of data. If she had Woody Woodpecker, am I dating myself, cartoons? If Woody had only gone to the police, none of this would have happened, right? If she had only asked earlier on about what his experiences were, I think she would have understood better some of the things that ended up transpiring. So take the time. What happened in that treatment? You said it was somewhat helpful. What was it missing? Carefully negotiate the therapeutic alliance. Do we get a lot of clients in the substance abuse field who, yep, that's me, I've got a problem and I'm coming to your door, and right? No, how do we hear about them? Family members, court, right? These are not people who are bringing themselves to treatment. And everyone who brings their loved one to you has their own ideas that they're not too hesitant to share with you about what that person's done wrong and what needs to change. But do we actually ask the client what they want to learn about? And I would argue that if you don't do this and don't get agreement on it in the beginning, it doesn't have to necessarily match and isn't always going to match what the family wants, what the loved one wants. But if you don't ask, you're setting it up to be at odds at the start. So one of the things that we do here at Altamira is I try to meet with each of the clients within their first week, and it's the first question I ask. What do you want to learn about? And my dad wants me to, no. What do you want to learn about? What do you want to work on while you're here? And I drill down on it until I feel like we've got kind of an agreement on what we're focusing on. And then I talk to our therapy staff and we try to build the treatment around it. It's a very important piece. When there's ruptures, you have to attend to them and repair them immediately. These aren't things that you can wait for. Because the dropout rate with these clients is so high, because they have so little ability to kind of modulate their affects, it becomes even more important to attend to the rupture when it happens so that it doesn't blow up and get bigger and they don't leave. Your time is really of the essence. Listen beneath the symptoms for the core recurring themes in the patient's life story. If we think that resistance is going to show itself, notice when it happens. Pay attention to it. Pay attention to the times when things are, going off task or starting to evolve into chronic crisis management. If it's going to happen and when it comes up, be curious about it. Very rare, unless they're cutting themselves in the middle of your office, do you actually have to do something right there and then. You often have time. Part of the behaviors is designed to stir you up, but if you're curious about it, so for Mr. Smith, for example, you're using again. What's going on in our work together? Something's obviously not quite working for you if this is still coming up. But be curious, stay curious. Listen for how the resistance makes sense given the patient's history. Not how we would think about it, but how, given what I know about them and their history, how does it make sense that Mr. Smith would start coming late to sessions or start to use again at this particular moment in our work together? How does it make sense from their perspective? How is the other person right? Doesn't mean, though, that we're not right also. Right? But if you don't see how they're right, you're not going to get very far with them. Okay? And don't take it personal. To the extent that some theme that's been in their relationships and lives for a long time is now starting to happen with you, then you're just another bump on their road. You're just another person that they're playing this theme out with. It's not personal to you. If there's things you're in reality doing that are stirring it up for them, you may want to attend to them, but it's not you. It's something that's transpiring between the two of you. And I have an old place I used to work, there was a nurse who was famous for coming into a shift change meeting and saying, "Can you believe that Mr. So-and-so did da-da-da-da-da to her?" And my answer was always, "Yes, Mr. So-and-so has a paranoid personality disorder. We've talked about how he's going to be prone to see things that you say in this way. Why on earth would we expect Mr. So-and-so to do anything but that? This is who Mr. So-and-so is." So it's not personal, it's part of what's happening. It's part of the condition. Okay? Explore and interpret the meaning of the self-destructive acts and attacks on the frame. Again, jumping down to the bottom, limits is only one piece. Consequences is only one piece. If you don't come back on the other end and explore what happened, why they did what they did, you miss a really important part of the puzzle. In my mind, and our colleagues at Austin Riggs, resistance and regression is often related to aggression. Now, as therapists, what's the nice way to say this? I think we are often, we're more comfortable dealing with the sad feelings. We're more comfortable dealing with the crying and the tears. And, we like being empathic. We're less good, I think, as a group at confronting people when they're mad or hanging in there when they're mad and angry and showing that side. It's just harder as human nature goes. But resistance is often related to aggression, relating and originating from the patient's rage and aggression. And I use the word rage on purpose. As we'll see when I go back to the example, you've all seen it, you've all felt it, I'm sure. Sometimes, though, the subtle expressions of the aggression, when you start to drill down, you realize, holy cow, there's a powder keg of dynamite down here that I didn't know was there and that the client didn't know was there. But that's the rage, and it's one of the things that's driving the behaviors you start to see. So an important tip then is when it comes up, you have to address it. You can't be afraid. You got to do it. Otherwise, treatment ends before it should. So how do we do that? Because it's really hard. So one way is to move beyond the notion of acting out, which if you think about it is a one-person paradigm. The person's just doing something bad or wrong or that they shouldn't do, to the concept of enactment, which is more of a two-person formulation. So going back to my nurse example, can you believe Mr. So-and-so's X, Y, and Z? Yes, I can, because he's got his part of the enactment, and the nurse couldn't see some of the things that she was doing that would feed into his acting in that way. So just to define enactment, the therapist unwittingly colludes with the patient in a process of mutual and complementary projective identification organized around significant past events from the lives of both participants. Now, that's a little wordy, so let me break it down, okay? Therapist has their stuff, client has their stuff, and they really mix badly, okay? And they get stuck there, playing out both of their parts, and therapy becomes playing that out back and forth, not therapy. So, what may look like at first a counter-therapeutic action by the patient is usually co-created. And you want to use your developing understanding of core interpersonal themes, not just of the patient, but of your own self, what you are bringing to the table, to inform you about what's happening between you and the client. So, let's talk about how this plays out and works with Mr. Smith. What's Mr. Smith's role in the enactment? Well, Mr. Smith had an actual history of being controlled by other people in his life, especially early on. And this isn't one of those old classical transference things, with the idea being that the client's kind of making stuff up and they're putting it out there. He is actually controlled, locked in closets and torn down and told what he can and can't do. Really happened. Okay? And his response was, of course, to feel belittled, shamed, blamed, and about this big most of the time. Okay? So about 1 month into the therapy, the therapist said, with the best of intentions, Mr. Smith, you need to go to more AA meetings. Okay? We know it's right, right? But let me point out some specific pieces of it. I think the minute we say you need to, with people like this, especially with this history, we've lost. Right? What do we really mean when we say you need to? I think we usually mean, I would really like you to, I need you to, X, Y, and Z. But really, when you think about it, there's very little the client actually needs or has to do. And if you start there with these treatment-resistant kind of folks, it primes it to be a combative kind of talk. So while not inaccurate, Mr. Smith ended up feeling controlled and belittled and shamed by the therapist. Unintentional consequence, perfectly reasonable thing to recommend in a treatment, right? But this is his response. And he responded to the injury initially with depression and regression, coming late, avoiding topics, being more passive, not doing homework. But when the injury, and I use that word specifically, it's a narcissistic wound, an injury to the client in that moment. When it goes unacknowledged, the feelings get bigger. He not only starts to feel controlled and belittled, but also unconsciously angry at his therapist and at treatment. And note here that the intensity of the angry feelings is amplified by his actual history of having those things happen to him earlier. So all those old times that's happened are coming back up and flooding him at the same time. And now, unable to put the anger into words, he starts to communicate it in more self-destructive ways, more and more serious relapses and becoming suicidal. So it takes two to tango, right? So what's the therapist's role in the enactment? Well, the therapist, in fact, had been feeling pretty annoyed that day. And despite Mr. Smith's words that expressed gratitude and appreciation for treatment, the therapist told me in supervision, you know, there's just something about it, I just don't trust it. It just doesn't feel genuine. You know, I mean, it's a month in, like, I'm really not that good a therapist. Like, you know, what's going on here? And so the therapist, in fact, had kind of a critical tone when she made the statement about needing to go to more AA meetings. And so as we talked about what was going on for the therapist in that moment in supervision, this is what we get to. So the therapist's own stuff had been triggered. As an adolescent, her mother would collapse into depressions and drink excessively. Her mother would become incapacitated, and other members of the family would have to literally and figuratively hold her up and offer her help. Sorry, I said he, it's supposed to be she. She would angrily confront her mother about alcohol use and its effect on the family. But, of course, mom would get defensive and make promises about changing the behavior that never came true. So she's primed to not trust the genuineness of her client's statements. So the therapist then starts, as an adolescent, to feel angry and frustrated by her mother's inability to be honest with the family and herself about her use. And so Mr. Smith, when he's not being genuine, the therapist picks up on it and feels pulled to help and to push the client to do more. So this is going to sound funny, but sometimes helping is countertransference. Sometimes your desire to make things happen faster, more quickly, better, stronger, is countertransference. So in this case, the reaction to push and help led the therapist to become more prescriptive and authoritarian. So she would, as the client's getting more and more passive, what's the therapist going to do? With best intentions, more homework, more prescriptive, at least go to one meeting, right? At least try one, at least do that. Right? But the more Mr. Smith gets depressed and passive, the more the therapist pushes, and eventually the therapist's efforts to hold up and push the patient left Mr. Smith feeling unconsciously that authority for his life, that authority for his body was being threatened again. So thankfully, after some consultation, the guy comes back out of the hospital, the therapist goes and meets with him. He came back to treatment, which meant something was going good enough in the beginning, which is a good sign. So the therapist, I tell her to go back and explore the meaning of what was going on, and I give her some ideas about how to do that. So Mr. Smith eventually acknowledges feeling controlled, belittled, and shamed by the therapist's comments and some other things early in treatment. The therapist then can start to help Mr. Smith make an association or a link between his experience of being controlled, belittled, and shamed and his depression, regression, and the early relapses that were happening in the treatment. But we don't stop there, right? That's the sad thing. Yes, I'm sorry, I was belittling you and controlling you. It's really sad when that happens, right? But we don't stop there, because the resistance escalated and became more self-destructive. And so in therapy, they started to talk about how his actions not only had a depressed and hopeless quality, but, excuse my language, more of a "fuck you" quality. Now, talking about the rage, Mr. Smith's exact words where, right? It's that deep, it's that core, right? So not only depressed, but there's anger and aggression in it, which of course, if you think about it, at that moment when you're feeling belittled, like everybody, it sounds a lot better and a lot more powerful and strong than belittled and about this big again, right? So resistance isn't just something to be done away with. If you're looking for how it's right, in that moment, it's his best solution to the problem. It's his best solution to the problem of feeling about this big in relation to someone else yet again in my life. Okay? Oh, one more back, sorry. So Mr. Smith comes to realize that his self-destructive behaviors invite other people to treat him, though, as lacking in personal agency and incapable of taking care of himself. And this gets actualized when he gets hospitalized. So it's more powerful in the moment. The longer-term consequence, though, is that he loses his authority for himself even more, which of course is going to feed the cycle. So he ends up feeling more controlled, shamed, blamed, things like that while he's in the hospital. So once they got hold of their two parts of it, it's kind of like a new way of understanding what happened. And armed with this new conceptualization, treatment can kind of get back on track, right? Mr. Smith and his therapist began to link their enactment of the core transference and countertransference theme to other themes, other important times in his life. For example, the therapist notices to Mr. Smith that he's talked about feeling controlled and belittled and shamed many times in his life with family members, previous therapists, and bosses. And that these had often led to his depression, substance abuse, withdrawal, and eventually the very absences that were causing him to lose his job and leave treatments early. So the patient and the therapist, in a way, had enacted in treatment the very issues that Mr. Smith's been wrestling with since he was knee-high to a grasshopper. Right? So some final tips. Treatment works best with these kinds of folks who are with this kind of resistance when it works toward restoring an individual's authority. Right? That gets a little touchy when the client's doing things that are showing you they're not in charge. I'm not saying give them all the authority, let them make all the decisions. You still have to hold their feet to the fire. They're still accountable. So it doesn't mean they can do whatever the heck they want. There's still limits. But to do it within the context of a human and therapeutic relationship. So I'll tell my clients, what happens between you and me is really important, and we're going to talk about it. Right? You and I are a subject of our conversation. What's transpiring between you and I, we are in a relationship. So if one of my clients is getting suicidal, yes, it's terrible, you're feeling so sad, all that stuff's true, but my next statement is often, so you're thinking about ending your work with me. Right? It's a different twist. It's direct. Her ending her life means she's deciding to end her treatment with me. What's going on between you and I that you're deciding to end your work, your relationship with me? It's a more focused, it's a sharper intervention. Even in the face of the rage and anger that's directed toward those in perceived authority, but if you think about it, those with the authority are also the people they depend on the most, which is often why it gets so confusing for them. How do I deal with being in the one down position but also needing them? Right? It gets very complicated. And one final pitch, when all else fails, use consultation and supervision. We sometimes have to check our pride at the door, right? It's not easy to ask for help, but sometimes the therapeutic dyad really does need a third, someone outside of the treatment, to be able to see the enactment, to be able to see what's happening between you. Sometimes our own stuff is just too up and active and we're just not thinking straight about it. Or we're too anxious, the client's got us too anxious about their safety to really think straight, to be able to have any reflective space. So often an outside perspective can help get the pair unstuck, and if all else fails, that's a good time to consider referring the client to a higher level of care. Okay. We'll stop there, and I think we've actually got some 5 minutes for questions. Comments, questions? It's all crystal clear now, right? Please.
A lot of what you were talking about sounds like motivational healing
Mhm.
work. So I just wondered if you use that a lot and how.
It's a great point. So I'm not, oh, sorry, repeating the question. So the question was, that sounds a lot like motivational interviewing. Do I do a lot of that? And I haven't actually gone to any of the motivational interview training. I've been through a couple of like hour-long CEU kind of things. I come from a more psychoanalytic and systems kind of background. That's kind of my integration. That's how people at Austin Riggs tend to think and work. But as I've gotten to know more about motivational interviewing, there's an easy overlap where they kind of dovetail. So I don't specifically do it, but I bet there's a lot of ways that they kind of hook up together. Please.
I actually found it quite psychodynamic, and I think part of that motivation is honoring the client.
Mm-hmm.
I really appreciate what you shared because you really put into words the process and psychodynamic stuff. I work in a crisis unit, so I see people like this on the table.
Yep.
So thank you for making it so clear.
Oh, you're welcome. Thank you. I should have said that earlier on. I'm always a little nervous when I've done this versions of this talk before. You know, in a way, I'm talking about kind of an outpatient or residential treatment. I know some of you are more on the intervention end of things. You may have a one-shot deal. I'm interested, actually, in how much applicability there is to those kind of more, even shorter-term kind of things, like a crisis thing. At Massachusetts General Hospital, part of my training there was working in the APS, the acute psychiatry unit. Mass General has their own psychiatric-specific ER, basically. And this comes in so handy, right? What do you want? What are you looking for, right? Oh, I can hear how you're right to be thinking about suicide, but, you know, how is ending your life the solution? You tell me you want to get a job and get your significant other back. Well, how does killing yourself get you there, right? So I'm curious, though, if people have ideas about how this applies to your work when there's a shorter time. I'm interested in that.
There's actually, thank you very much for your talk. It's really informative.
Sure.
But what you're talking about now is actually was my question is, how do you deal, like, within, you know, a therapeutic, you know, within the office between a therapist and a client, I get it, you know, I get all
Mhm.
that. Like, I work in a sober living environment where, you know, in the total there's 40 clients, right? And
Mhm.
they all want as much time as possible, right?
Mm-hmm.
So you get the client that kind of mopes around all the time and doesn't look at you, but you know they want your attention, you know?
Mm-hmm.
So the question is, you know, how do you apply this within in the context of a residential treatment facility or a sober living environment, whatever it is, a therapeutic community? Because once I offer that client my attention, it's like, I mean, it's endless.
Yes, the bottomless pit of need
Yeah.
kind of experience, right? Well, I mean, first, I mean, I don't have the exact answer. It's a
And
great
I don't know,
question.
that's not a real good question. Yeah, but
Actually, it's a perfect question. I think, I mean, I'm open to what other people have to say too. I mean, there's a lot of collective wisdom and experience here. So my own thought is, one, are they also in treatment with somebody else? It might not be your role to kind of go into that. Sometimes yes, sometimes no. But
they're resisting treatment somewhere else.
yeah, exactly, right?
Yeah.
Right. So that's important, though, to communicate to the treaters there. Hey, we're noticing this. You're a part of the team. You have to see yourself that way. You see the person a lot more than the therapist does. You know them much better on a cellular level, probably, than that therapist does. You're an invaluable member of the team. So your experience, the way I think about it, whoever's the individual therapist is kind of the hub, and their job is to collect different people's experiences of their client and try to feed them into their developing understanding of the client that they're working with. The other thing I would say is spend some time talking with them about their history, about their family life growing up and what they experienced. That will guide you if you do end up talking with them, because I get you need to hold some limits there, but it will guide you in what you can expect will happen if you do end up working with them.
Yeah. Thank you.
One more question, or are we done? One more question? Please.
I just wanted to say that I work right now specifically with women and who often don't even know they're angry because of the way that women
Yep.
often will express it differently.
Yes.
You know, sort of just enroll them in that idea.
Yep, that's usually the place I start.
Yeah.
Start by seeing that side of it. You know, it's protecting a really vulnerable part of you when you collapse or when you don't go to your session or whatever it might be. Uh-huh. You know, we actually just had a client here where we were talking about, you know, all that's true, and sometimes there's a way that the relapse happens that is hostile, right? It is a direct communication to whoever's holding the purse strings or whoever it is, and so when you're talking about it, I mean, you can also start to fold that in. Yeah, and when you collapse and call your dad when you're on the bridge, that's hostile. You're mad. I mean, you have to do some education because they don't see it. It's the unconscious part. It's the furthest thing that they think they're doing, you know, from their mind. Thanks, everybody.